Hello everyone, I'm Dr. Ankita Singh, Reader, Department of Oral Pathology, Babu Banarsi Das College of Dental Sciences, Lucknow, and today I will do lecture on cementum. So in this lecture, I have included microscopic pictures and other pictures which are used for educational purpose only. So what is cementum? It is mineralized dental tissue covering the anatomic roots of the human teeth. So cementum is found in the roots because it covers the roots. It begins at cervical portion of the tooth at cemento-enamel junction, which we can say as CEJ, and it continues to the apex. It is considered as a part of periodontium, and it furnishes attachment to the periodontal ligament fibers, which we can say as PDL fibers. It makes functional adaptation of the teeth possible, and unlike bone, human cementum is avascular. Now this is the picture which is showing all the structures in the teeth. As we can see enamel covering the crown, we can see dentine. Then in the center, we can see the pulp chamber. Then the root part, we can see the cementum, the periodontal ligament, and also we can see the alveolar process that is marked. This is the picture of a periodontium in which we can see all the structures, the alveolar bone, and especially cementum also we can see. The physical characteristic, its hardness is less than that of enamel, dentine, and bone. It is yellow in color and it is lighter when it is compared with dentine. It can be distinguished from enamel by its lack of luster and its darker hue. That is, it lacks the shiny surface. It is semi-permeable to variety of materials, and we should know that it is thinnest near cervical region, approximately 20 to 50 micrometer, and then it gradually becomes thicker as it reaches the apex, approximately 150 to 200 micrometer. Now the chemical composition, it contains inorganic substance which is 45 to 50% and organic material and water, and it is 55%. The principal inorganic component is hydroxyapatite, although other forms of calcium are present at higher levels than enamel and dentine. And we have also traces of copper, iron, fluoride, magnesium, sodium, zinc, silica, and potassium. And we should know that cementum has the highest fluoride content of all the mineralized tissue. Organic portion consists primarily of type 1 collagen, which is 90%, and small amount of collagen type 3, 5, 12, and 14. Also, non-collagenous protein are present, which are proteoglycans, alkaline phosphates, osteonectin, osteocalcin, osteopontin, sialoprotein, and growth factors. And it should be noted that cementum attachment protein create a pool of cementoblastic population, which helps in regeneration of supporting structures of tooth. Functions of cementum, it is anchorage, adaptation, and repair. Anchorage provides medium for attachment of periodontal ligament fibers, thereby it helps in binding of tooth to the alveolar bone. Then adaptation, masticatory forces causes occlusal wearing, so there is decrease in tooth length. So continuous deposition of cellular cementum at apical region compensate for it. Then repair, deposition of cellular cementum repairs fracture or resorption occurring in roots. Now what is cementogenesis? It is the process of formation of cementum. So organic matrix and collagen fibers are formed. Fibers in cementum are derived from cementoblast. Ground substance and organic matrix, they formed by cementoblast. So we should remember the name of the cell, that is cementoblast. Now the process, the development of root begins after the crown is formed. So under the influence of inner enamel epithelial layer, outermost layer of dental papilla gets converted into odontoblast, so which deposit the radicular dentine along the inner aspect of Hertwig epithelial root sheet. So in the picture also, we can see inner enamel epithelium and Hertwig's epithelial root sheet. Then outer enamel epithelium can also be seen. So after that, unlike in coronal portion where inner enamel epithelial cells become ameloblast and they form enamel, in the radicular portion of Hertwig epithelial root sheet, it gets invaded by cells of the dental follicle. And these some cells of the dental follicle which come in contact with newly formed radicular dentine, they differentiate into cementoblast. And then cementoblast, as I have said, in turn deposit cementum over the dentine. Now the cellular components of cementum. The cementoblast, which is very important. Soon after Hertwig's sheet breaks up, undifferentiated mesenchymal cells from adjacent connective tissue differentiate into cementoblast. So they synthesize collagen and protein polysaccharides, which make up the organic matrix of cementum. The cementoblasts have numerous mitochondria, well-developed Golgi apparatus, and large amount of endoplasmic reticulum. They have vesicular nucleus with 2 to 3 nucleoli. So this is the picture of cementoblast. The cementoid tissue, the newly deposited cementum in organic matrix consisting of collagen and ground substance is called cementoid tissue. So this cementoid tissue is uncalcified matrix. Mineralization of cementoid is highly ordered event and not the random precipitation of ions into the organic matrix. And as cementum formation continues, fibers of the developing PDL, the Sharpie's fibers, are embedded in the cementum and serve to attach the tooth to the surrounding alveolar bone. We should also know about cementocytes. Sometimes cementoblasts are entrapped in a matrix during deposition. So the cementoblasts are entrapped in a self-generated matrix. So then they are called cementocytes. They are seen in space called lacunae in mineralized cementum. And in the picture, the arrow ones, they are the cementocytes. Now the structure of cementum. Under light microscope, two types of cementum can be seen and they are acellular and cellular cementum. So we should know the difference between acellular and cellular cementum. Acellular cementum is primary cementum. Cellular cementum is also called secondary cementum. Acellular cementum does not have spider-like cementocytes incorporated into it. By the name only, it is acellular. And acellular cementum is found at coronal half, whereas cellular cementum is found at apical half. Cementum is thinnest at cemento-enamel junction and thickest towards the apex. And cementocytes are either degenerating or are marginally active cells. The primary cementum, it is the first form cementum. As I said, it is acellular, develops slowly as tooth erupts, extending from cervical portion to coronal two-thirds of root. It is formed before tooth reaches the occlusal plane. Then thickness is 30 to 230 microns. It is thinnest at CEJ and thick towards the root apex. Also, it contributes to the length of the root. It consists of intrinsic and extrinsic fibers. Sharpie's fiber make most of acellular cementum. Sharpie's fiber in acellular cementum is completely calcified. They have principal role in supporting tooth within the jaw. The secondary cementum, it forms after tooth reaches the occlusal plane, and it consists of extrinsic and intrinsic fibers, and Sharpie's fiber make a small portion of this and are separated by collagen fibers. This cementum is formed faster. It is present in apical third, interradicular portion of the teeth. Usually, it is cellular cementum, which continuously contributes to the root length. And incremental lines have less collagen and more brown substance than other portions of cementum. So this is the picture showing cellular and acellular cementum. Acellular cementum covers the root adjacent to dentine, whereas cellular cementum is found in the apical area. Acellular cementum, as I've said, is primary cementum, and cellular cementum is secondary cementum. So this is the microscopic picture of acellular cementum and cellular cementum. Now the classification of cementum. Schroeder classification, it is very important. It can be classified as acellular afibrillar cementum, that is AAC. Contains neither cells nor extrinsic nor intrinsic collagen fibers except mineralized brown substance, and these are produced by cementoblast and is found in coronal cementum. Then second is acellular extrinsic fiber cementum, AEFC. It is composed almost entirely of densely packed bundles of Sharpie's fiber that are derived from but no cells. It is found in cervical third of roots, but sometimes may extend further apically. The third is cellular mixed stratified cementum, CMSC, composed of extrinsic, that is Sharpie's fiber, and intrinsic fibers, that are collagen fibers, and may contain cells, co-product of cementoblast and fibroblast, apical third of roots, epices, and furcation areas. The next is CIFC. It is cellular intrinsic fiber cementum. It contains cells but no extrinsic fibers. Derived almost entirely from cementoblast, it fills resorption lacunae. Then intermediate cementum, it is poorly defined zone near the cemento-dentinal junction of certain teeth, and it contains remnants of Hertwig epithelial root sheet embedded in calcified brown substance. Then other classifications are there. Based on cellularity, it can be acellular cementum and cellular cementum. Based on tissue of origin, can be primary or secondary cementum. Based on collagen fibers, can be afibrillar, fibrillar cementum. Then based on origin of matrix fibers, it can be extrinsic cementum, intrinsic cementum, mixed fiber cementum. Now the cemento-enamel junction. This is the junction between the cementum and enamel at cervical portion of the teeth. This is very important, cemento-enamel junction. Three types are there. Sharp junction, which is also called bud joint, gap junction, and overlap junction. So I'll show you the picture first. The first picture is present 60% and it is overlap junction. In this cervical end of enamel, it is overlapped by cementum. And then second picture is 30% and it is sharp junction. The cervical end of enamel meets the cementum, and the third is the gap junction. It is 10%, and cementum and enamel, they don't meet. So overlap junction, most common, seen in 60% of the teeth. Cementum overlaps the cervical end of enamel for a short distance. Occurs when reduced enamel epithelium covering the crown degenerates near the cervical region, permitting the dental sac to come in contact with enamel. The cells differentiate into cementoblast, thereby deposit cementum over the enamel. The sharp junction, seen in 30% of all teeth, cementum meets the cervical end of enamel in a relatively sharp line. And the gap junction, seen in 10% of the teeth, enamel and cementum do not meet, and there is no CEJ. A portion of root in cervical region is devoid of cementum. This may be due to delay in degeneration of Hertwig epithelial root sheet, thereby preventing the contact between dental sac cells and dentine. Thus, there is lack of cementoblast differentiation. So remember the three types of junctions. Then there is cemento-dentinal junction also, junction between cementum and dentine. Smooth in permanent teeth, scalloped in deciduous teeth. Then dentine is separated from cementum by a zone known as intermediate cementum layer or hyaline layer of Hopewell-Smith. Appears structureless and does not show features of either cementum or dentine. This layer is predominantly seen in apical 2/3 of root of molars and premolars. So this hyaline layer of Hopewell-Smith is important. In the picture, A is acellular cementum, B is hyaline layer of Hopewell-Smith, C is Toombs granular layer, and D is root dentine. Now, what are the incremental lines? They are highly mineralized areas with less collagen and more brown substance than other portions of the cementum. So, incremental line of Salter, the rhythmic deposition of cementum is represented by these lines. And they do not have regular rhythmic distribution. They are unevenly spaced. Like in the picture, we can see they are unevenly spaced. So incremental lines in acellular cementum are arranged more regularly and evenly than in cellular cementum. Counting of these lines of acellular cementum has proven to be a reliable indicator of age and events in life which evoked a disturbance in metabolism. Resorption and repair of cementum. Cementum, we should know, is more resistant to resorption than bone. Thus, in orthodontic tooth movement, resorption in bone rather than cementum occurs. So this is very important. It is because bone is richly vascularized, whereas cementum is avascular. Now, local causes of cemental resorption, it can be trauma from occlusion, there can be cyst or tumors or periapical pathology, there can be excessive orthodontic force or embedded teeth, replanted and transplanted teeth. Systemic causes of cemental resorption are deficiency of calcium, deficiency of vitamins A and D, and hypothyroidism. And we should note that in repair or deposition of cementum, cementoblast help. This repair is a process to heal the damage caused by resorption or cemental fracture. So repair in cementum occurs in two ways. Anatomical repair, the resorbed area is completely filled with cementum. Continuity of the root surface and periodontal attachment is re-established. And there is functional repair. Resorbed area is partially filled. So bay-like defect is seen on roots. So the alveolar bone forms projections to establish normal physiologic width of the periodontal attachment. Aging of cementum. Smooth surface becomes rough due to calcification of small bundles of ligament fibers at their place of attachment. It occurs at all surface except apical area, where continuous deposition occurs, leading to closure of apical area. So cementum can resorb for some time and deposition can take place for some time, creating reversal lines. So that is all for your lecture. Thank you.